Welcome, everyone, to the University of New Mexico Law and Mental Health Didactic Series, hosted by the University of New Mexico Department of Psychiatry and Behavioral Sciences, along with the New Mexico Behavioral Health Services Division. We're so glad to have you joining us today. I'm Anthony Perillo, the Forensic Psychology Training Director here in the Department of Psychiatry and Behavioral Sciences at the University of New Mexico. A couple of things before we start today. If you have any questions for our presenter, you can ask them in the Q&A box anytime that you feel comfortable. Just know that we do hold those questions until the end. We do try to get to as many as possible, but sometimes we can't get to them all, so just forgive us if we can't get to yours. For those of you that are pursuing continuing medical education credits, there will be a sign-in for the APA for those CE credits right now in the chat box, so you should have access to that link now. For those that are pursuing APA continuing education credits, you do have to wait until about the last 5 minutes or so of the presentation. Make sure you open that link before you leave the webinar and save your certificate after you complete the survey, because we do not keep access to those copies. We don't have access to them later on after the fact. As a heads up, there will be a recording and a link for the PowerPoint slides available later today. And for next week's talk, we will have Dr. Drew Kingston, who will be covering perspectives and management of compulsive sexual behavior disorder. But that's for next week. This week, it's now time to introduce our presenter here, who you've been waiting for. I'd like to introduce you to Dr. Lauren Gonzales, who will be discussing social determinants of mental health in legally involved populations. Dr. Lauren Gonzales is a clinical psychologist and assistant professor of medical psychology and psychiatry in the Division of Behavioral Health Sciences and Policy Research at Columbia University, Irving Medical Center. She completed her doctoral degree in clinical psychology with forensic emphasis at John Jay College and the City University of New York Graduate Center. She completed her postdoctoral fellowship at the University of California, San Francisco Medical Center, and spent several years as an assistant professor of psychology at Adelphi University. Her research evaluates social determinants of mental health and recovery among individuals with serious mental illnesses using mixed methods and direct engagement with vested parties. She's received prior funding from the New York State Office of Mental Health and is a current Office of Mental Health Policy Scholar. I'll also add she was also an APA rep consultant to address stigmatizing language in TSA policies about people with mental illness, which led to an additional pushing to address faulty stigmatizing rationales for some of those very TSA policies. Dr. Gonzales, Lauren, on behalf of the University of New Mexico, can I say how excited we are to have you joining the series and honored that you'll be sharing your expertise with us today. I will go ahead and throw it over to you.
Thank you so much, Anthony. Yeah, thank you so much for having me. It's truly an honor, and I'm so happy to be here. Let me just share my screen. Okay, can you see that okay? Great. Yeah, so I've titled my talk "The Social is Personal," because I truly believe that when kind of thinking about social determinants, when we are looking to promote mental health equity, especially in forensically involved populations. I'm going to take us through, there are a few initial slides I will just go through quickly. But to my learning objectives here today, I have a few. So first, kind of getting started on describing social determinants of mental health as relevant for individuals with criminal legal involvement and severe or serious mental illness, which I'll refer to as SMI. Then also examining the role of service providers in fighting mental health disparities that can result from stigmatizing attitudes. And then also explaining the importance of stakeholder collaboration in research, practice, and policy efforts for these populations. I'm going to start with number one. And in my work, especially in my research, I usually start off with a problem that I want to learn more about. And I'm a clinician scientist, right? So I'm a clinical psychologist. I was trained in clinical psych with a forensic focus. And as a result, my training was very individually focused, right? So we're learning evidence-based assessment and intervention to help people with symptoms that they find distressing or that are getting in the way of them reaching their goals, right? And so as I started working in different community mental health centers and in different forensic settings, I found myself quickly becoming really frustrated, right? As a service provider, I had learned these individual evidence-based treatments and interventions, But I was working often, and I think many of you on this call will also, have similar experiences, but working in these really transient, often very chaotic settings with folks who had many immediate needs that, would make it really difficult for them to be able to prevent or to engage in treatment in a way that would benefit them, right? So things like coming in with immediate housing needs, right? Not knowing where they're going to sleep that night, or even food insecurity, things that would make it really difficult for us to, be working in these evidence-based models that didn't really account for some of those other things. And so from this, I encountered this revolving door, right? Which many of us are familiar with. Working in these settings, we tend to see these subpopulations or subgroups of clients who tend to kind of circle through these treatment settings without seemingly improving in terms of symptoms or their goals that they have for themselves, and kind of just coming through over and over. And so I became interested in looking at the various contributors to this revolving door problem that I was seeing so much clinically, and specifically zooming out and getting a more broad look at the potential contributors to this problem, thinking more about contextual factors, so that, instead of just working at the individual level with each person who keeps coming through, some kind of common denominators that we might be able to identify that we could target on a broader scale. And so this led me to the social determinants of health and mental health literature. And this, is a widely growing field. Social determinants of mental health are taken from the social determinants of health literature. And this figure is a model of Bronfenbrenner's ecological systems theory. And basically within this theory, right, we have that individual within that smaller circle in the middle with all of the, individual characteristics we often consider. But we also consider that individual within a larger context, and also with additional interaction between all of those levels. So interacting across time through these different systems that you see all around it, but also, across these levels and over time. And so thinking about this and looking into the literature, I noticed that, SMI, which is a population that I tended to work with most often in community and forensic settings, people with SMI tend to display all of these disparities across these different levels. So that's where the revolving door would be put within this model. But people with SMI on average display higher rates of poverty, higher mortality and premature mortality rates, higher levels of housing instability, higher incarceration rates, and then also higher rates of violent victimization compared with the general population. And then they also experience lower employment rates and, significantly lower mental and physical health outcomes compared to non-SMI populations. And so in the work that I will be focusing on today, and much of my work has been in this area of housing instability and, increased criminal legal involvement among folks with SMI. And again, really looking at this, from a contextual level, in addition to those individual characteristics that might contribute to some of these disparities. And so this led me to think about SMI and housing specifically. And this is from a systematic literature review that found that, anywhere between 20 to 50% of the estimated unhoused population in the United States are estimated to meet criteria for SMI. And this is compared with maybe about 4 to 5% SMI that we see in the general population. And then among folks with SMI who are unhoused, we see lifetime arrest rates ranging between 48 to 67%, depending on the study, compared with maybe about 6% in the general population. Right. So, when I see statistics like these, I have a lot of questions in mind. I'm thinking about, well, how are we measuring housing, or what it means to be unhoused or unstably housed? How are we measuring serious or severe mental illness, right? Which my work has also looked at. But, regardless of all of that, on the face, these statistics are quite striking, right? In terms of SMI, housing instability, and criminal legal involvement. And, with these statistics in mind, there have been, several different treatment models designed to target this disparity itself. Things like, supported housing models for people with SMI and alternative to incarceration programs, including mental health courts. And so I'm going to share a project with you that focused specifically on mental health courts and this issue of housing for folks with SMI who are involved. And this was a project I did while I was at UC San Francisco Medical Center. And so to give you some brief overview, if you're not familiar with mental health courts, they are an alternative to incarceration program, started in the early 1990s and pretty widespread now. And they involve a separate docket for individuals with mental illnesses where they receive mental health assessments. And there's usually a voluntary entry point into the mental health court if they're deemed eligible. And then from there, usually the mental health court kind of links them with mental health treatment services. And there is shared decision-making between the judicial system, the judge, and the treatment program that the individual is linked with. And so they're, connected with these treatment programs, and, while they're completing it, they're under judicial supervision. And then upon graduating from their treatment program, this is usually associated with a reduction in charges or sentencing, depending on the mental health court and the jurisdiction, what the rules are there. And so we know from the literature, there have been quite a great deal of positive outcomes that we've seen from mental health courts, things like reduced recidivism, rearrest rates, and reduced violence for people who participate. But, again, what I was interested in, and especially considering those statistics I just showed you, was how housing might fit into some of these beneficial outcomes that we see for mental health courts. So I asked, first of all, does participating in a mental health court influence people's housing? And then also could, if that is the case, could housing be one potential kind of more systemic structural mechanism of change for one of these beneficial outcomes we see, violence reduction for people who participate in mental health courts? And so, as I mentioned, I looked at these data when I was at UC San Francisco. This was taken from the MacArthur Mental Health Court Study, and our sample included folks who were recruited between 2005 and 2008 from the San Francisco court system. They had completed structured interviews at enrollment into the court and then 6 and 12-month follow-up periods. Housing instability had been measured as whether they'd spent, any nights homeless in the prior 6 months at each assessment period. And then violence was taken from self-report and also confirmed with legal records. And so for our mental health court sample, we had 88 new enrollees into the San Francisco Mental Health Court. And TAU included 81 individuals who had been eligible but not referred for whatever reason to that San Francisco Mental Health Court. And then our samples were also matched on these various demographic and clinical characteristics as well. And so previous analyses with these data had already found that there had been a significant relationship between participation in the mental health court and violence at the follow-up period. So people who had been, accepted into the mental health court and completed their treatment programs had a significant reduction in violence compared with treatment as usual. But again, I was interested in looking at how housing could fit into this relationship that we already knew was there. And so here's what the sample looked like. You can see across mental health court and TAU, average age around 38, 39, with about 10 years standard deviation, majority identified as male, a large proportion as Black and Hispanic. And then the only real significant demographic difference between mental health court and TAU was that mental health court participants had a higher proportion with schizophrenia diagnosis, and TAU had a higher proportion with major depression. And then across both, very high rates of substance use disorder diagnoses. And so first we wanted to look just at kind of these different variables we were interested in across the various assessment periods. And so you see here at baseline, this shows the percentage or proportion of participants across the samples who had reported spending at least one night unhoused. And no significant differences here, right? Across both the samples, maybe around 40% reported that they had spent at least one night unhoused in the prior 6 months. But then here's follow-up housing, right? You can see that TAU kind of still lingered around, maybe 35 to 40%. Mental health court was reduced, quite significantly. So mental health court participants were less than half as likely than TAU to have become unhoused or spent time unhoused at follow-up. And then we looked at the relationship between housing status and violence at follow-up. And we can see here that unhoused participants were 4 times more likely to have perpetrated violence at follow-up compared with housed participants. And so, pretty powerful just looking at these proportions and testing them for significance, but we also wanted to test this in terms of a mediation model, right? Looking at the potential for housing to kind of fit into that relationship between mental health court participation and violence reduction. So we use the process macro for SPSS here, and this is what our mediation model looked like. And statistically, what we found was that housing at follow-up significantly mediated the relationship between mental health court participation and reduced odds of violence at follow-up, such that, when we included housing status in the mediation model, that previously significant relationship between mental health court participation and violence at follow-up became non-significant. So some limitations that I do want to point out from this study, right? One thing that we did was that, in the data that we were using, which is pretty typical with this type of sample, folks tend to be lost to follow-up periods when you're trying to follow them over time. And so as a result of that, we ended up combining the 6 and 12-month follow-up periods to maximize our sample size. And as a result of that, we had kind of the mental health court versus TAU at baseline, and then we had housing and violence at follow-up, right? So we did have that timeline where we had different time points for the sample and the outcomes. But we did not have different timelines for the housing and the violence risk. So, unfortunately, for me, that means that I can't determine statistical causality at follow-up. But what it does tell us is that we can still conclude that the housing status at follow-up did matter significantly in terms of that relationship between mental health court participation and violence. The other limitation that we had thought about with this sample was that, we used the San Francisco Behavioral Health Court, and that mental health court was considered a second generation mental health court. And second generation courts tend to consider for acceptance people who have more serious charges, including felonies, more significant violence histories, and substance use disorders. And so at the time we thought, oh, well, maybe this is a limitation for generalizability. There are still a lot of first generation mental health courts out there. But since the study was done, we find that the prevalence of these second generation mental health courts have been steadily increasing. And then kind of more broader implications from what we saw with these data. It suggests that, housing is a potential mechanism of change for some of these beneficial outcomes that we see in some of these alternative to incarceration programs for folks with SMI. So kind of giving us a sense of, okay, if we're zooming out, right, and thinking not just about this individual and their mental illness symptoms and how that could be related to their involvement with the criminal legal system, there are other avenues that we can be looking at that are, just as, if not more so, impactful. And so thinking about housing instability as one of our holistic treatment targets, right? And really thinking about, if we're setting these programs up for success, can we figure out ways to link them with community resources and services such as housing services, right? To build that up for people who are participating. Okay, and moving on to the second objective, really thinking more about stigma, which has been a common thread in the work that I've done throughout my career, working with folks with SMI and legal involvement, and how providers can play a role here. So I'm going back to this ecological systems theory because stigma, I think, really is so impactful because it impacts every single level of this system, right? So we have mental illness stigma, and it works at this macro system, right? Kind of the attitudes and ideologies of the culture, because stigma, by definition, involves social and cultural attitudes and behaviors toward a group of individuals that we determine has some socially undesirable trait, right? So that is determined by what we as a society think of as, the social norm and what we think of as deviant. At the exosystem, stigma, involves somewhat of a social learning process, right? Where we learn attitudes and stereotypes about mental illness through these different social systems, things like from our neighbors, from our social welfare systems, from the mass media and the news media and television and movies, right? All of these things kind of tell us what it means to have a mental illness or what mental illness is associated with. And we tend to learn these things over time through these social processes that sometimes we might not even be aware of. And then at the microsystem, we know that stigma is associated with perceived rejection and can be a significant barrier to community integration and development of relationships, which often is a huge part of recovery from mental illness. Then at the individual level, we have self-stigma, right? Where an individual can internalize negative attitudes and stereotypes that are part of the label of mental illness and believe them to be true of themselves. So an example of this might be, I get a diagnosis of schizophrenia, and I've learned that having schizophrenia means that you're violent and that you can't work. And so as a result, I start to believe, well, I'm never going to be able to work again, right? And, I might be unpredictable and, I shouldn't be around my family anymore because I might, put them in danger. And then stigma also, we know, changes over time, right? So what we think about mental illness and different psychiatric diagnostic labels has absolutely changed over time. And I see this as a good thing because, I see it as a dynamic factor, right, that we can actually intervene upon. And so, yeah, kind of really emphasizing that it's kind of integrated into all of these systems. So if we're thinking about the individual within the context, stigma is present within all of these areas. And then I also like to, whenever I talk about mental illness stigma, just to illustrate how socially powerful it is, I like to give in some examples. And so I wish I could do a poll and get a sense of how many of you have seen this before. It's a really famous example in the stigma literature. So this is from the New York Daily News, and it says, "Get the violent crazies off our streets." And, honestly, if I didn't know any better, if I hadn't seen this before, I might, take a guess that it came out relatively recently. It actually came out, I think, in 99 or 2001, or around that time. But I have some more recent examples. Living in New York City, we have tons of them. So this is also from the New York Daily News from this past fall. And this was in a piece that was commenting on, the perceived increase in crime in New York City post-COVID, and also, what we perceive to be a housing crisis. And, there's been a lot of discussion in New York City around, well, there are tons of like, quote unquote, mentally ill and homeless people kind of roaming the streets. And so this is just a quote from a passerby, saying you go out late at night and people are still trying to rob you. It's primarily the mentally ill and the homeless. It really doesn't matter to the mentally ill and the homeless, like they don't care, right? And then here's the New York Post, and these are some headlines from the last 6 months, right? So maniac suspected of hijacking MTA bus, leaves judge almost speechless, or Queens man shot by cops was mentally ill, increasingly unhinged. And so I'm showing these just to kind of give a sense of the use of language and how powerful that can be, right? So violent crazies, unhinged, maniac, very derogatory words to refer to people with mental illnesses, clearly not person-centered, right? Often we tend to try to use, person with a diagnosis of instead of defining someone by their label, and really promoting this sense of us versus them, right? So the New York City streets belong to us, not those crazy people. Get them off our streets, right? And then, of course, the stereotype that mental illness is linked directly with violence. And, that's kind of what causes all of these social problems that we're seeing. And so, we learn these stigmatizing attitudes through these social processes. We see it all around us all the time, right? And all of the different avenues for content that we see. And it's really pervasive, right? It's really kind of pervasive within our social lives. And, when I say it's pervasive, it really does affect everyone across levels as this social process. And that, that includes people off the street who you might interview for a New York Daily News article, but it also includes mental health providers. And so that's what I kind of wanted to get a sense of in this next project I'm going to share with you. The rationale, we know that from the literature, we know that treatment providers are not necessarily immune to stigmatizing attitudes, right? It is this pervasive social process, it gets in there. So that's been established. And we also know that marginalized populations with SMI experience treatment disparities, specifically racially minoritized individuals, people with unstable housing, and people with criminal legal histories. And so for this project, I was interested in, first of all, how treatment providers might compare with community members on measures of mental illness stigma. So although we knew that providers can, exhibit stigmatizing attitudes, that direct comparison had not been made. And then also I was curious about whether mental health treatment provider attitudes could vary based on some of these client characteristics, including race, housing status, and criminal legal history. And I kind of got the idea for this project, again, through some of my clinical experiences working in really, crisis settings, forensic settings, where you have to make decisions very quick on your feet, and people are kind of coming in all of the time, just really fast-paced crisis settings. And, those types of settings are, from what we know about stigma, really a breeding ground for, having to make fast-paced decisions, having to rely on some of those cognitive shortcuts, things like stereotypes, right? And when we think about stereotypes, oftentimes they come from somewhere, right? There's some tiny kernel of truth, even if the stereotype itself is widely, not based in the literature that we know. And so, you might have had an experience where there was violence on an inpatient unit, and that, becomes what you expect, 100% of the time. And especially in fast-paced settings, that's going to be much quicker to happen in terms of how you make decisions. And so I was curious on how this might play out with these specific stigmatized populations that we see. And so we created an online survey using Qualtrics, and we had a sample of treatment providers, including we had medical students, we had doctoral level psychology students, and then we had licensed clinical psychologists, and we recruited them using snowball recruitment kind of to our networks and beyond throughout the United States and Puerto Rico. And then we also had a community sample that we recruited through Amazon's Mechanical Turk. And everyone received a vignette that they read of a man named Harry. And this was adapted from Pat Corrigan's attribution questionnaire. And with this vignette, we randomly manipulated Harry's race, housing status, and criminal legal history. And I'll show you what that looked like in a minute. And then everyone filled out quantitative measures of stigma toward Harry and mental illness more generally, and then also qualitative measures. And so here is kind of the standard vignette that everyone received, right? So Harry is a 30-year-old man diagnosed with schizophrenia and hypertension. He's coming into the emergency room, right? Kind of fast-paced setting with complaints of back pain. He lives alone and has been previously hospitalized because of his illness. Harry grew up in Boston and moved to New York City to finish school, right? Some more details about his background. And he works in food services and enjoys listening to music. And so in blue are the characteristics that we randomly manipulated. So Harry was described as either being Black or white, living alone in an apartment, or being currently homeless. And then we either included this sentence, he also has a history of arrest and misdemeanor charges of fare evasion, or we left it out. And we chose fare evasion because, again, we're in New York City, and that tends to be a lot of folks' entry point into the legal system. And then all of the treatment providers received a few qualitative items, right? So we wanted to get the quantitative kind of attitudes toward Harry, but we also wanted to see, okay, well, could their treatment decisions also be different, right? Kind of more qualitatively. So we asked, what are your current ideas about what brought Harry to the ER? And remember, all of the vignettes said that he was coming in for pain. So everyone saw that, but we asked this question anyway. And then what additional information would you want to know about Harry? And what treatment follow-up would you recommend based on the limited information that they received? So some sample characteristics here, you can see across the samples. In terms of identified gender, those psychology samples tend to be a larger proportion self-identified female. Mostly white sample that we ended up with, except the medical student sample had a larger proportion of Latinx ethnicity. In terms of age, kind of made sense. The licensed psychologists and community samples were older on average compared with the trainee samples. And then just some kind of various characteristics in terms of, for the providers, what types of settings they were working in, and the length of training and years that they'd been providing care. And we were controlling for some of these in our analyses as well. And so if you'll remember, our first research question was just getting a sense of how treatment providers, how that sample was comparing with the community sample across different measures of mental illness stigma. And so this is the attribution questionnaire, which measures kind of endorsed stereotypes toward Harry, the vignette. And so things like questions like, how fearful would you be of Harry? How likely do you think Harry would be to, be compliant with treatment? Kind of similar questions to that. And you can see across samples here, the medical students were really spiked. And higher means more negative stereotypes endorsed. So medical students had more stereotypes endorsed toward Harry compared with the community sample or psychology samples. And that said, the psychology samples were not so different from the community sample, right? Even though the medical students were spiked. We also gave a measure of mental illness microaggressions, which involve kind of more subtle negative behaviors that you might engage in towards someone with a mental illness. And it showed virtually the same exact pattern where medical students were spiked, community members and psychologists and psychology students were kind of the same pattern that you see in this graph. And then we gave a measure of reported, it's a reported and intended behavior scale, which essentially measures desire for social distance from people with mental illnesses. And you can see here that the community sample kind of rose to meet the medical students. So those were both elevated. endorsing kind of more distance desired from people with diagnoses, and the psychology samples lower in comparison. So would be more willing to kind of have someone with a diagnosis as a neighbor or as a friend or as a coworker. And then moving to the second research question, getting a sense of whether these attitudes might be different based on the characteristics that we had manipulated. We included some variables that we already know from the literature tend to be associated with stigma. And this was consistent with the literature. So people who were identified as male gender tended to hold more negative or stigmatizing attitudes. And then having worked with psychiatric populations before among the providers was associated with lower stigma. And then across the vignette characteristics, first of all, race was not a significant predictor of stigma. But housing status and arrest history were, such that when Harry was described as homeless and with an arrest history, attitudes were significantly more negative. And then we also found a significant interaction between housing and arrest history. And I'll show you what that looked like. Here's what that relationship looked like. So essentially, when Harry was not described as having any prior arrest history, so that sentence was not included, no arrest history mentioned. When Harry was described as housed in an apartment, attitudes were much less negative, less stigmatizing, compared with when he was described as being homeless. They were much more negative, right? But then that dotted line shows when Harry was described with an arrest history. And you see that regardless of his housing status, attitudes were negative, right? It really pretty much didn't matter. So that effect of housing went away, and it was just negative attitudes if he had an arrest history. So pretty important for us, those of us who work with people with arrest history, just kind of showing how powerful that can be in terms of how they're perceived by providers. And then we wanted to take a look at the qualitative findings. And so what we did was we went through the answers that the providers gave to those qualitative questions around, what do you think brought Harry in? What would you recommend? Where would you send him next? And we did some thematic analyses and came up with codes. And then we also wanted to see if there were any statistically significant differences in the codes that were coming up when Harry was described as unhoused versus housed and with arrest history or no arrest history based on the quantitative findings. And so when Harry was described as homeless or unhoused, compared with when he was described as housed, providers from our sample were more likely to conceptualize what was bringing him into the ER as being due to a lack of resources. So people would say things like, oh, Harry was probably, coming in complaining of pain because he slept on the street last night and maybe he has a backache from that, or he slept the wrong way or something. And they're more likely to ask about addiction and kind of suggest that, oh, well, maybe he's medication seeking and coming in for pain medication. And then they're also more likely to ask about mental illness history and how potentially a schizophrenia might be linked with his pain in almost like a psychosomatic manner. And then they're also more likely to suggest referring for social services as their kind of treatment follow-up for his pain. When Harry was described as having an arrest history, compared with no arrest history mentioned, providers were significantly less likely to conceptualize what was bringing him into the ER as pain or anything pain-related. And they were also significantly less likely to refer Harry for any follow-up evaluation or treatment for his pain. And as a reminder, everyone got that same sentence of Harry's coming in with complaints of back pain. So when he had the arrest history in the vignette, it's as though that other sentence didn't exist, like it kind of just canceled it out. And so, this told me a lot of things, right? From the first research question, we saw that providers in our sample their stigmatizing attitudes really weren't that different from community members in our sample. Sure, the medical students were elevated, but even the psychologists and the psychology trainees, they weren't significantly different across our stigma measures compared with the community sample, which I was hoping that it would be, but in our sample it was not. And then we also saw some support, right? A lot of the stigma literature focuses on attitudes, but we also saw support that maybe some of these attitudes could translate into differential treatment. So we didn't see that for race, right? And my team and I thought a lot about this, considering all of the literature, on racial disparities and the biases that can underlie that. And we thought, well, maybe it could be a limitation of the vignettes, right? We're kind of like using it, people are reading about it. Maybe it's not activated in the same way that bias would be activated if it were in person. But we also thought about it as well, maybe the housing status and the criminal legal history were so powerful in terms of the bias that, it overpowered any influence of racial bias that, could come out from that vignette. And then based on the qualitative data, right, we found that, some of the stigmatizing attitudes that providers were endorsing could potentially be linked with treatment quality and treatment disparities, right? So there was evidence for differential treatment of Harry depending on his housing status and arrest history, such that they weren't even considering that he was coming in with his chief complaint if he had his arrest history. And so this tells me, right, of course, this is just one sample, but thinking about this as, well, maybe there is potentially some link there. And, if that's the case, provider attitudes are a really key intervention area, right? Thinking about this as, first of all, we know from the stigma literature that attitudes and behaviors, there's not always a direct link there, right? So if there is some influence that we're seeing play out from this sample, that means that's a key area of intervention where if we can figure out a way to intervene so that provider attitudes and biases aren't influencing the way that we treat people in high impact crisis settings, then that could really make a huge difference down the line and kind of, counteracting some of these disparities that we might see. Okay, and so the last thing I'm going to talk about today is kind of thinking about, and this is going along with my more current work and some of the projects that I'm starting, thinking about how we're doing the work that we're doing and really considering the importance of collaboration with the stakeholders that we're trying to work with for research, practice, and policy efforts. And so coming at you with the problem again, and this is a problem that I think has been really pervasive historically throughout the mental health services research and forensic mental health research. And this is pervasive throughout many fields as well. But when we're doing clinical and policy research, it's often research that's being done on people, right? And this can involve, researchers who may or may not have any mental illness lived experience or lived experience as service recipients in these systems. But, we're the ones kind of deciding what the research questions are, deciding which data that we collect. And oftentimes we're also the ones interpreting those data, right? And, we just saw that providers are not immune to stigma and biases. It's the same thing for researchers, right? And so we all have these biases, but also we might just have different priorities, right? Or we might have only one perspective and we're not kind of seeing, again, that broader zooming out scope and considering additional solutions. And so there have been calls to kind of change the way the system works. And this is coming from the psychiatric survivor and disability rights movements, but this quote, right, nothing about us without us, really trying to promote direct collaboration directly with the communities and groups of individuals who we're hoping to serve and support through the work that we do. And so I'm not going to go too deep into, the projects that I have in these areas, but if anyone is looking to discuss this more, I'd be more than happy to. But these are just some solutions that I've kind of been thinking about and starting to incorporate into my own methods. And, I'd like to share them with you as well. So on the research end, thinking about more stakeholder engaged research, and then also community-based participatory research. And so, if we are doing research that's, for example, evaluating programs or evaluating policies, really making sure that we're doing so across different areas and across different stakeholder groups, right? So we're not just getting one perspective, but we're really making sure that we, are talking with all of the parties who have, a vested interest in, whatever it is that we're evaluating. So in New York City, I'm part of a group right now that is going to be, you're all kind of thinking about it together and figuring out what's going to be important to everyone involved for you to be looking at. And so I've used that recently in a project where we developed kind of anti-mental illness stigma toolkits for distribution in different neighborhoods in New York City, including East Harlem and the South Bronx. And then more in the practice and policy arena, but also in research, we have things like advisory councils and collaborative advocacy networks. And these are things that I've been really wanting to build up more and get established more in my areas and in the decisions that we make. So if we're making decisions that are impacting others, from a service or policy standpoint, we really don't have to be doing that alone, right? And be kind of doing it, implementing it, and then seeing the feedback kind of after we've already done it. So really making those decisions together can, first of all, save us a lot of work, but also make it truly collaborative from the beginning. And so I'm on a couple of advisory councils for research at Columbia where people are looking at the association in first episode psychosis and violence, for example. And we have people from, people with lived experience, family members. We also have treatment providers, people with forensic experience, right? Just kind of getting as many diverse perspectives as possible in kind of trying to set up these types of projects. And then with the collaborative advocacy networks, really basically just trying to capitalize on the availability of these advocacy organizations that are based in the community as we're thinking about who we can collaborate with and how we can kind of engage with these types of voices with the lived experience who we're trying to serve through the work that we do. And so, yeah, just some ideas and methods, again, that I've been looking to integrate, and I'd be happy to discuss those if there's any more interest. But for now, that is all I had for you. So my references there that I should show, but yeah, Anthony, if you wanted to take over, I can stop my share if that works.
Sure, completely up to you.
Yeah.
But yes, thank you so much, Lauren, for that thought-provoking discussion and just the overall emphasis on the need for collaboration, whether it's bringing people to the table to just have their voices heard, as well as multiple perspectives into bringing this research, as well as dissemination, and just how many people that this work does potentially apply to. For those of you that have additional questions, you can enter them in the Q&A box now. Dr. Gonzales will stay for a few minutes to answer some questions. I'll throw a couple that are already out there your way. This first question here asks about the interest in drug treatment has increased with the change in demographic of who society considers quote unquote addicts. How do we get society to buy in to general mental health treatment in the same way instead of fear mongering?
Oof, that's a great question. I really do wish I had the answer. I'm fascinated by that though, just really following, because we see the same thing in terms of just mental illness attitudes in general, right? Like who are we identifying as the groups of people who have this problem, right? In New York City, right, in previous decades, we had like the crack epidemic, right? And that was this huge fear mongering, people thinking that it was these specific neighborhoods and these lost causes, and the legal implications and policy implications for that were so different than what people are considering now. And even thinking about things like the legalization of cannabis, right, and who is profiting off of that. So we're seeing real differences, and policymakers, I think, are becoming more aware of that. And I think that's one of the benefits of these more collaborative methods that we're seeing gain more prominence. So really that, being able to collaborate with the voices of people who are being served and targeted by these policies, I think is one of the most important tools that we have in order to kind of promote that visibility. But I also think things like social media, right, as much as it can be harmful, I think it also has helped to get the word out about some of these things. I've worked with many students who kind of found their way into the social determinants of mental health world by things that they saw online and things that they kind of did their own research on, and saw was something that really bothered them and they wanted to know more about. So I think we can really capitalize on things that bother people and those kind of emotional reactions that people can have as a way to get them to be more curious about some of these disparities and really spread the word about it, I guess.
Thank you. Yes. This question came right around the time I think that you were wrapping up the discussion of the qualitative findings, if that provides some context here. This person asks, most providers I know would not have taken this survey. They would have gotten a request to participate and concluded, oh, this researcher is just trying to make providers look bad. The curiosity is, did you do any analysis of qualities of the providers who did or did not participate? What sort of participation level did you actually have?
That's a great question. So because we use snowball recruitment, we weren't able to collect any data on people who just didn't click the link, right? Which absolutely could be, a limitation. I will say, though, also, we weren't just targeting forensic providers. So I think that's a limitation, too, is that, many of the providers who took the survey likely didn't have any forensic experience. And they're also, we had 2 of our provider samples were in training. So they, didn't have, I guess, the sense of distrust that maybe other providers who've been working in that area for longer might have. But the way that we kind of described the study too, I think was relevant. So just getting a sense of treatment decision-making, not necessarily looking at biases, but just different attitudes that people might have. So definitely, I think it could be a limitation, but we don't have the data on who did not participate.
Always a mighty task there to keep track of that. Yes. This question came in at the tail end here. Someone asked, though race did not show a difference, and I think this is a direct difference, because arrests did, in the real world, race will definitely play a role, right? Given the disproportionate arrest incarceration rates in the US for Black men and women.
Mm-hmm. Yeah. I totally see where that question is coming from. I think it's just, from our methodological standpoint, it was really difficult to, we don't know how to conclude from our lack of a racial finding what that potentially means, right? It could mean that the effect's not there. It could mean that the vignettes didn't point it out. It could mean that, just in our sample, it wasn't the case. But I would be very hesitant to conclude anything from that kind of lack of finding that we had. But I do think the findings that we did have, despite all of that, are even more powerful. Same thing with the, fact that many people might not have responded because they didn't want their biases to come out, right? The fact that we still found what we found, maybe in a biased sample that didn't think they had any stigma, is pretty important.
Certainly. I'll throw one last question your way. This one is, do you think the importance of housing is due to the reduction of stress, or is it because it's providing a structured environment for patients that often does not allow drug or alcohol use, provides medication administration, gives case managers a reliable place to locate patients? And then they added the caveat, this is assuming patients are going to group homes and not to privatized apartments.
Yes. Big caveat there for sure. And that really depends on where you're at too, and what services are available. So in New York City, I've also done a lot of work looking at housing first models where it's really just getting you into housing, right? And there are no kind of contingencies around substance use or, you know, medication adherence or things like that. And those show significantly beneficial outcomes in terms of mental health and community reintegration. I think, you know, and this is coming from, I guess, the clinical aspect of it too, if you put enough stress on anyone, they're going to start to, you know, have symptoms of mental health symptoms, right? And so not having a stable place to live and to even, you know, have a place for your things and be able to sleep at night without being, you know, hypervigilant that someone's going to be violent towards you. I think all of those are things that we tend to take for granted, which, you know, I think also highlights the importance of having multiple perspectives in, you know, having that seat at the table when we're designing these projects and policies. But we cannot underestimate the impact of the stress for unstably housed individuals. And if you work with them in the clinical context, you see that as well.
Dr. Gonzales, Lauren, thank you so much for this very helpful presentation and this idea of not just addressing stigma, but calling out, you know, us at the table that we do contribute to the issue as well, and the need to address stigma not just being a broader macro issue, but that it also is a individual within our professions and all that as well. That wraps up another Law and Mental Health series. We hope to see you next week with Dr. Drew Kingston talking about compulsive sexual behavior disorder. Until then, have a fantastic rest of your week and take care.
Thank you so much.
Absolutely.